Hello, good evening, everyone. I'm Dr. Mukar Sangeeta Dilprasonone, and I welcome you all back to the recall session of Fmge. So this is the third session. I apologize for the delay. But no worries, we have discussed 125 questions already in the last two sessions. If you haven't seen that, those two sessions, I would recommend you all guys to go through once. All of those who are really anxious about the results, please calm down. Everything will fall in place, okay? So here we are with the third session of your recall, because I was getting constant requests for the third session. Apart from that, all of those who will be appearing in the June 2022 examination, for those also, these questions would be really helpful, because definitely the topics would now bit changing. The topics would have been changing a bit in these recent patterns. So definitely you can go through these questions as well for your preparations. They will definitely help you get an edge over the others. Okay, so with this, without any further delay, I would like to start the session. But before that, I would just like to highlight the point that Fmge will have already announced the upcoming batches for June 2022 session. If you people are interested, please do contact Fmge office at the given contact numbers. You can also contact via the Telegram groups. If any issues, please reach out to me as well in via Telegram. Okay, so let's begin with our session without any further delay. So let's start with the first question for today's session, and the question states, cholesterol is synthesized from. And guys, I would like to highlight one more point that I have highlighted in the previous two sessions also. As these are the recall questions, they might not sound similar to the exact exam questions. Maybe the options would differ a bit. Okay, if you have any issues, please don't hesitate to comment down or to just text me personally about any changes in the question pattern or the options that you feel were there in the examination. Okay, so with that, cholesterol is synthesized from, and the options are phenylalanine, acetyl coenzyme A, heme, and bile acids. I hope this was a pretty straightforward one, and I hope all of you are quite aware that cholesterol is synthesized from option B, acetyl coenzyme A, definitely covered by Dr. Priyansh in sessions, also by Dr. Bharti, right? Important one. So it was a pretty straightforward one, not much to be discussed in this, right? Then question number 127, which of the following is seen after a meal? Okay, after meal, definitely what will happen after a meal, the glucose levels inside the body will increase. As the glucose levels inside body will increase, to counteract this increased glucose levels, which hormone should come in action? So to counteract this increased glucose levels inside the body, insulin will come in action, right? So the beta cells of the islets of the pancreas will start secreting insulin to counteract this increased glucose. Therefore, increase in insulin should be seen, right? First thing. On the other hand, a pro-glucose hormone, that is your glucagon. So glucagon should decrease, because now as the body has enough amount of glucose, there is no need of glucagon to be activated, right? That's the reason why there would be decrease in the glucagon level. This was again a pretty straightforward question. After a meal, usually to counteract the increased glucose levels, there should be increase in the levels of insulin. On the other hand, there should be decrease in the levels of glucagon, because we have always seen that insulin is always an antagonistic hormone to glucagon. Rather, insulin is always an antagonistic hormone not only to glucagon but also other hormones like growth hormone or your cortisol, right? I hope this was pretty clear, because already discussed in your Fmge biochemistry notes also by Dr. Priyansh. So it was very easy for you to solve this question. I hope so. No issues with this. With this, moving forward to our next question, question number 128, and the question states, a patient who was a known case of gallstones underwent cholecystectomy. What is expected after the surgery? So this was a bit out of the box question, but it was pretty easy to guess this question, because other options were very easy to be ruled out, right? So a patient was a known case of cholelithiasis, and therefore he underwent a cholecystectomy, that is removal of your gallbladder. So what should be seen after the surgery? What is expected to be seen? So in this case, let's rule out. I do not have the fourth option. Like I had got few options, but I didn't find them quite a fit for the fourth option. Therefore, I would request you to add up this option if you remember from the examination day. So please remember, guys, hypoglycemia would be seen if there is something related to the pancreas, right? So it would have been our guess if there was something related to the liver or the pancreas in any case. So hypoglycemia would definitely be not an option. Weight loss is not seen after any cholecystectomy or any of the gallbladder surgeries for sure. So what happens usually? Gallbladder stores what? So important thing is gallbladder stores bile. Right, so bile contains your bile salts as well as bile acids. Important. And bile salts and bile acids are responsible for emulsification of fat. Okay, they are responsible for emulsification, or we can say in simple terms for digestion of fats. Right, because digestion of fats as such, it starts in the oral cavity itself by the enzyme lingual lipase. Right, so fat digestion itself starts in the oral cavity, but it is broken down into smaller pieces, or it is emulsified, we can say, when it comes to the intestine. Okay, when it mixes up with the bile. So definitely the action of bile on the fats will lead to its proper digestion. So if in cases the gallbladder is not present, if the concentration of bile acids and bile salts goes down in the bile, okay, such kind of bile will definitely not help in emulsification of fats. So what will happen? The undigested fats will definitely directly be excreted out in the stools. Right, so such kind of undigested fats which are directly excreted out in stools will lead to this condition, option A, known as steatorrhea. Steatorrhea is what? Fat in stools. So therefore there would be fat forming, bulky, kind of foul smelling at times. Such kind of stools would be there. Okay, so after gallbladder removal, the concentration of bile will go down. Okay, so the bile will not be concentrated because the concentration of bile salts and bile acids will go down, as it is the function of gallbladder. So as bile salts and bile acids are less, therefore emulsification of fats would not be proper, and that therefore it would lead to excretion of these undigested fats into the stools, which is known as steatorrhea. I hope this was pretty clear. Moving to our next question, question number 129, where it states a patient who was a known case of COPD, that is chronic obstructive pulmonary disease, is currently on salmeterol therapy. Okay, salmeterol is what? So salmeterol is a LABA, that is a long-acting beta-2 agonist. I hope this is clear. Salmeterol, we have discussed about the drugs of acute asthma and pharmaceuticals also in first class. Also you would have discussed this. So please remember, it is a long-acting beta-2 agonist, salmeterol. So a patient of COPD was on salmeterol therapy, but no improvement is seen. Which of the following drug should be added to this regime? So please remember, usually LABA or SABA inhalers, okay, meter dose inhalers are given to the asthmatic patients or the COPD patients. So in this case, improvement is not seen even after taking salmeterol. So in such cases, what is the first step to be done? So please remember, according to the guidelines that we have for acute asthma or for COPD, first of all, definitely either a SABA is given in cases of attacks, or a LABA is given in case for maintenance, right? So maintenance के लिए we give LABA, whereas for acute episodes or attacks we give SABA. But if improvement is not seen with either of these drugs, definitely we need to add one more drug, again in the form of meter dose inhalers, and this drug would definitely be a M3 blocker. Okay, if this drug should definitely be a M3 blocker. And such kind of M3 blocker is known as tiotropium, ipratropium like drugs. I hope this was pretty clear with everybody. So muscarinic blockers are to be given, because what happens with muscarinic action, there is bronchospasm, right? So therefore bronchodilation would occur if we give some M3 blocker, that is drugs like tiotropium. So the second step after giving a SABA or LABA is to add a M3 blocker, option A, like tiotropium. Okay, or ipratropium bromide. So any of this would be added. If no improvement is seen with these two drugs also, then definitely we can add corticosteroids. Okay, so corticosteroid inhalers can be given after that. So please remember, that would be your third step. But after LABA, definitely tiotropium is the first step to be added. Right, I hope this is like not an issue with many of you. If this question have gone wrong also, don't worry, there would have been many questions that we would have marked correct. Okay, Next is question number 130. A person was brought to the emergency in comatose state after consuming some unknown poison. So such questions have come earlier also. The poison's name was not directly given, or nothing was given in the description of the poison as such. Okay, they have just mentioned an unknown poison. You need to guess the kind of poison depending on the symptoms. Okay, and what were the symptoms given? First of all, the patient was in comatose state. Second, excessive sweating is present. On examination, bradycardia is noted and BP is 80/60 mm of Hg. Which of the following is the antidote for the treatment? So first of all, let's guess the type of poison. So what is the kind of poison that the patient might have ingested? So first of all, comatose state तो बहुत सारे poison से हो सकती है. Next keyword is excessive sweating is present. Okay, important thing, definitely sweating as such is a feature of the adrenergic system, right? All of you are quite aware that sweating as such, we have discussed this in chantings also, that sweating as such is a feature of adrenergic system. But one punchline that I had given, that was all other places in adrenergic system, noradrenaline or adrenaline is the neurotransmitter, except at places of sweat gland where acetylcholine is secreted. Right? So indirectly what happens, whenever there is increased acetylcholine activity, there would be excessive sweating. Right? So definitely this is a kind of cholinergic poison. Let's confirm it further. On examination, bradycardia is noted. Definitely in cases of adrenergic, there would be tachycardia. So if there is bradycardia, that definitely means that it is a kind of cholinergic poisoning. Let's confirm it even further. BP is 80/60. That means the patient is hypertensive. In cases of adrenergic poisoning, the patient would have been hypertensive. The BP would rise in cases of fight, flight or fright. That we have discussed already. So therefore, the patient is also suffering from hypertension. So all of these point towards a cholinergic type of poison. And the cholinergic type of poisoning that we have discussed already many a times, मैंने बोला भी है that it is a सरकारी question. It is most likely resembling OPC poisoning. Right? It is most likely resembling a OPC poisoning. Though they do not mention about other secretions like salivation, lacrimation, etc., but they have definitely mentioned about one of the kind of secretions, and that is sweating even. Right? So there is excessive sweating, there is bradycardia, hypertension, which is pointing towards a cholinergic type of poisoning resembling OPC poisoning. Therefore, the antidote for such kind of poisoning should be a drug which can counteract cholinergic poisoning, and cholinergic poisoning can be counteracted by a drug like option C, atropine, which is a anti-muscarinic agent. Right? All of these are muscarinic symptoms. Therefore, to counteract all these symptoms, option C, atropine, is a life-saving drug or the drug of choice in such cases of poisoning. This we have discussed already. N-acetylcysteine we discussed. It is used in cases of paracetamol toxicity. Physostigmine like drug, it is usually used in cases like myasthenia gravis वगैरह में दे सकते हैं, right? Along with that, neostigmine is a drug of choice for cobra bite, and it is to be given along with atropine again. Okay, this we have discussed already. So I hope this was pretty clear with everybody. Next one, question number 131. A 10-month-old child is undergoing treatment for diarrhea with hypokalemia. So the child is suffering from diarrhea along with hypokalemia. Along with fluids, potassium correction was done, in spite of which the child does not improve and floppiness is noted. Which of the following is the likely cause? So now there was a 10-month-old child. The child is suffering from diarrhea as well as hypokalemia. So as we all know, the first line management for correction of diarrhea would be rehydration, and that is done with fluids. So the child was given fluids, and for hypokalemia, potassium correction was done even. Okay, whenever there is hypokalemia, there would be muscle weakness, right? All of you are quite aware of this now. Right, whenever there would be hypokalemia, there would be muscle weakness, the tone of the muscles will decrease, leading to floppiness. So that was the reason for his floppiness, we guess. But even after correction of this potassium, the child's condition did not improve and floppiness was still noted. So what was the reason for this floppiness even after correction of potassium? So let's see. Option A says albumin deficiency. Albumin is the major protein in the plasma. But in cases of albumin deficiency, there would be decreased plasma oncotic pressure, and which will rather lead to edema, right? Which will rather lead to generalized edema like anasarga that we have seen in cases of nephrotic syndrome vagera, or it is also seen in protein energy malnutrition, that is kwashiorkor, important, right? So edematous child would be seen in kwashiorkor. So definitely this is not the cause. Next we'll discuss about phosphate deficiency. Definitely phosphate and calcium will have some action on the bones, okay, not a likely action on the, at least phosphate will not have such a major action on the muscles. Next, if I discuss about calcium, definitely calcium deficiency can lead to action on the muscle, and it will rather cause tetany, right? It will cause spasms, it will cause cramps, it will not cause floppiness rather, okay? So tetany is not noted in the child. Therefore the answer to this question would more likely be option B, magnesium deficiency. If not potassium, then the second likely ion which is responsible for muscle weakness, fatigability and floppiness would be magnesium, okay? So there is loss of potassium as well as magnesium in cases of diarrhea. When the mucus is lost, in that cases, apart from potassium, magnesium is also magnesium should also be given in some cases. Okay, so this was the answer. Question number 132. A 3-year-old child presents with cough and fever and inability to feed for 2 days. On examination, chest indrawing is present. Respiratory rate of 42 per minute. What is the management? Now this is pretty clear that they had to ask you something about the IMNCI guidelines, right? Integrated management for neonatal and childhood illnesses, right? And I have already told you in the sessions that IMNCI guidelines are important, guys. You at least need to remember the guidelines for pneumonia, important diarrhea. At least these two I have recommended you to go through them once. So if you haven't gone through, then definitely this question would have been difficult, but agar tukka bhi lag gaya ho, then great. Let's see what was the answer to this question. So now they have given a 3-year-old child. As we all know, usually IMNCI guidelines are for children from 0 to 5 years of age, right? From 0 to 5 years of age ke liye we have IMNCI guidelines from different conditions like measles, diarrhea, pneumonia, okay, all of these. So 3-year-old child with cough and fever, okay, so these are the two important symptoms, cough and fever. Along with that, there is chest indrawing and the respiratory rate of 42 per minute. If a child more than if a child of 3-year-old is having a respiratory rate of more than 40 per minute, okay, here the child is having a respiratory rate of 42 per minute, that means it is suggestive of increased respiratory rate or tachypnea, right? So one of the features is tachypnea, second feature is cough, third feature is fever, fourth feature is chest indrawing. So all of them are likely suggestive of what? These are the cardinal symptoms for pneumonia, right? So they're definitely asking you about pneumonia. Cough, fever, tachypnea, chest indrawing, all are suggestive of pneumonia. So there are 3 categories. Either there would be no pneumonia, there would be pneumonia, or there would be severe pneumonia, right? All those given by green, yellow and pink color boxes if you remember the IMNCI guidelines. So apart from these important features which are suggestive of pneumonia, so that means the child is having pneumonia, right? If there is chest indrawing, there is tachypnea, cough and fever, that means the child is suffering from pneumonia. But along with all these findings, a very characteristic important finding was given, and that is considered as a general danger sign, and that was inability to feed. If the child is having inability to feed, or any of the general danger signs for that matter, okay, when the child is lethargic or the child is unconscious, so any of such signs if noted, definitely they are considered one of the general danger signs. And any one of the general danger sign, even if present in the question, that is suggestive that the child would be suffering from severe pneumonia, right? The child is suffering from severe pneumonia. So important, please remember, if the child was suffering from no pneumonia, definitely you would just do the basic resuscitation and then ask the mother to follow up after 5 days, okay? Just home-based care would be given to the child if the child was having no pneumonia. If the child was having pneumonia, definitely you will give antibiotics at your level and then ask the mother to have a follow-up after 5 days. This was in conditions of pneumonia. But if the child is suffering from severe pneumonia in this condition, what should you do as a medical officer over there? You should first of all give the first dose of antibiotics and then refer the child immediately to a higher center or to a hospital. Right? So important is this one. The answer to this question would be option C. Give the first dose of antibiotics and then refer the child immediately to a higher center or to a hospital. Right? So this was to be done in this question. Then next is question number 133. Which among the following condition is associated with hypocalcemia, thymic hypoplasia, microdeletion of chromosome number 22q11.2? This we had discussed in one of our questions. We had it in our options, and all of you are quite aware. So all of you who have attended the classes would have have these things in your notes also, and definitely we have discussed this also in the chanting sessions. So this was the mnemonic that you all remember, catch 22. So catch 22, where C usually goes for cardiac anomalies, right? C goes for cardiac anomalies, we can say, or cardiac abnormalities, where A goes for abnormal feces. A goes for abnormal feces. T goes for two conditions. First is thymic hypoplasia, right? T goes for two conditions. First is thymic hypoplasia, and second is it is a T cell abnormality. Okay, T cell abnormality. Whereas C next would go for cleft lip or cleft palate, right? And last H goes for hypocalcemia, and 22 would go for a microdeletion on chromosome number 22. Microdeletion on chromosome number 22. So this catch 22 is actually the mnemonic for which condition? Yes, very good. It is the mnemonic for option C, D-George syndrome. So usually in this congenital anomaly, that is D-George syndrome, here there would be a microdeletion on chromosome number 22 at the 11th loci, due to which there would be some cardiac anomalies in the child. There would be abnormal feces. There would be thymic hypoplasia. And as there is thymic hypoplasia, there would be hypocalcemia, and due to this hypocalcemia, the child can even suffer from neonatal seizures or neonatal tetany. And along with that, there is also one more anomaly, that is a cleft palate, right? And it is a T cell abnormality. So I hope this was covered in pathology also, this was covered in other medicine also, pedia also. So this was very easy for you all to answer. Down syndrome, definitely it is trisomy 21, so definitely it can be easily ruled out. Turner syndrome, again it is a monosomy 45XO, so again it's easily ruled out. You might have been confused with Prader-Willi syndrome, but we have discussed Prader-Willi syndrome in pathology also. In genomic imprinting मैंने बोला था, right? Prader-Willi, P for Papa, P for Prader-Willi, ऐसा करके अगर कुछ याद आ रहा हो, that we have discussed in pathology sessions in genetics. I hope this was pretty clear and easy to answer. Moving further, question number 134. A 12-year-old child was brought to the OPD. He appears to be anemic and previous history of multiple blood transfusions is given. Lab values reveal hemoglobin is 8 gram per deciliter. MCV is 75 femtoliter. Peripheral blood smear shows microcytic hypochromic RBCs. Which of the following should be the next investigation? So now, अगर कुछ नहीं पता होगा, mnemonic अगर पता थे anemia के, तो भी it would have been easier for you guys to at least come to a provisional diagnosis, and then you would have marked at least the correct answer to this question, right? So they have given a 12-year-old child was brought to OPD. The child is anemic and there is a previous history of multiple blood transfusions. If a child is having a history of multiple blood transfusions, definitely there is some genetic abnormality, and that is more likely to be in cases of thalassemia. Okay, the child has anemia. Okay, there is some genetic abnormality, and the child has received multiple blood transfusions in childhood itself. So definitely it would either be thalassemia major vagara. Okay, lab values reveal hemoglobin of 8 gram per deciliter. That means anemia is present. MCV is 75 femtoliter. As we have discussed in the class itself, you would have discussed in pathology sessions also, that the normal MCV is between, if I see a rough value, it is between 80 to 100 femtoliters. Right? And we have discussed less than 80 would be microcytic, more than 100 would be macrocytic. So in this they had given that it is 75 femtoliters. Definitely it should be a microcytic anemia, and the same thing they have given in the peripheral blood smear even, that it was a microcytic hypochromic picture of the RBCs which was seen, right? So which of the following should be the next line investigation? As we all have discussed that for microcytic hypochromic anemia, the mnemonic we discussed was SITA, where S was for sideroblastic anemia, I was for iron deficiency anemia, T was for thalassemia, and E was for anemia of chronic diseases, right? So anemia of chronic disease, more commonly it shows normocytic normochromic anemia, but it can definitely also show microcytic hypochromic anemia. ये सब डिस्कस हो चुका था. So in this definitely please see guys, in iron deficiency anemia there would not be any history of multiple blood transfusion, rather in the child there would be a history of eating non-nutritive substances like pica वगैरह या koilonychia, such kind of history would have been given. Sideroblastic anemia there would have been history of lead poisoning वगैरह, okay, and anemia of chronic disease, no chronic illness was mentioned in the question as such. So and important marker was this one, multiple blood transfusions in a child is most likely a marker of thalassemia amongst all the options that we have. Alright, so definitely our provisional diagnosis becomes thalassemia, mainly thalassemia major, because recurrent blood transfusions are required in thal major as discussed. So now they are asking which of the following should be the next line investigation. So now please remember guys, we have discussed already that serum ferritin is the investigation of choice for iron deficiency anemia, right? Then if I talk about direct Coombs test or DCT is the investigation of choice for autoimmune hemolytic anemia, right? So important one. So autoimmune hemolytic anemia would have been our choice if no history of multiple blood transfusions was given, or mainly even if multiple blood transfusion history was given, important thing was peripheral blood smear would have shown normocytic normochromic anemia and not a microcytic hypochromic anemia, right? So then our diagnosis would have inclined towards AIHA, otherwise it would not be AIHA. Next, osmotic fragility test. Osmotic fragility test is definitely a screening test used in cases of thalassemia, sickle cell anemia, but definitely a better investigation will be HB electrophoresis. As discussed in this condition also, please remember investigation of choice is HPLC, high performance liquid chromatography for thalassemia, but if it is not an option, the second best answer would have been hemoglobin electrophoresis. This we have discussed already. So I hope this was pretty easy for all of you to come to a diagnosis. Next, question number 135. This question states that a 17-year-old patient presents after starvation. Lab evaluation reveals unconjugated hyperbilirubinemia with normal liver enzymes. Which condition is suspected? So now guys, this was pretty easy for all of you. So now, first of all, the patient is suffering from unconjugated hyperbilirubinemia. Okay, that means the unconjugated bilirubin has increased, and the mnemonic that I had for unconjugated hyperbilirubinemia was CG, right? Whereas for conjugated hyperbilirubinemia or conjugated jaundice, I had the mnemonic that was doctor, right? So important, like I remember it likewise, that doctors are civilized, and the rest you all know. So so doctors are civilized, that why I remembered it as DR for conjugated hyperbilirubinemia, right? Where D goes for Dubin-Johnson syndrome, right? D goes for Dubin-Johnson syndrome, R goes for Rotter syndrome. So these are two important congenital conditions which can lead to conjugated hyperbilirubinemia, right? Apart from this, conjugated hyperbilirubinemia is also seen in cases of obstructive jaundice. Okay, I hope this was pretty clear with everybody. Whereas unconjugated hyperbilirubinemia is seen in CG, where C usually goes for Crigler-Najjar syndrome, right? C goes for Crigler-Najjar syndrome, and second G goes for Gilbert syndrome. So with this, it was quite easy to come to a conclusion that in cases of Gilbert syndrome, usually it would be unconjugated hyperbilirubinemia. Important thing guys, important thing, definitely unconjugated hyperbilirubinemia can even be suspected either in cases of pre-hepatic jaundice or hepatic jaundice. Pre-hepatic jaundice can be due to increased hemolysis, okay, but no such history of anemia vagara is given in this condition, and no such condition of anemia is also mentioned in the options even. Second, it can be hepatic cause. Important thing, if we mention about a hepatic cause like acute viral hepatitis, definitely unconjugated hyperbilirubinemia can be seen in the early stages, but the important thing being the liver enzymes would be highly elevated. The SGPT, SGOT enzymes are highly elevated in cases of hepatitis. Important thing. So definitely it can be ruled out. If there is normal liver enzymes mentioned in the question, definitely hepatitis can be ruled out easily. Dubin-Johnson syndrome, as discussed, is a cause of conjugated hyperbilirubinemia, whereas chronic pancreatitis, definitely it would mainly lead to conjugated hyperbilirubinemia. Right? So the answer to this question would directly be option C, Gilbert syndrome. Question number 136. A child presents with gum bleeding and muscle weakness. The below given image finding is seen. What is the likely deficiency? Now some people mentioned that there was a patch. Some people mentioned that there was some small hemorrhage like petechiae were there. Okay. And same side मुझे बताई गई थी, like near the lateral canthus of the eye there was some bleeding or some petechiae वगैरह were present. Okay. So this was pretty straightforward question. Okay, in chanting also discussed, in biochem notes also you would have. So vitamin C deficiency, that is a child suffering from scurvy will have bleeding gums, right? So what is the reason for that? As we all know, important, vitamin C or ascorbic acid, it acts as a cofactor for many of the enzymes, and one of the enzymes important is lysyl oxidase. Okay, and this lysyl oxidase enzymes, these are usually used in cases of collagen. Okay, collagen synthesis mein this lysyl oxidase is used. Hydroxylation of proline, hydroxylation of lysine, these are usually done by these enzymes. So if vitamin C or ascorbate is not present in sufficient quantities, definitely these enzymes would also not work. If these enzymes would not work, definitely the collagen would not be properly formed. And if collagen is not properly formed, there would be a defective collagen which is formed. And if there is a defective collagen formation, it can definitely lead to recurrent gum bleeding, or it can also lead to muscle weakness, right? Important. And definitely multiple petechiae all over the skin. So this was discussed in the questions itself. So the straightforward answer to this question was option C, vitamin C, right? So vitamin C deficiency or scurvy will lead to multiple gum bleeding or multiple petechiae all over the body along with muscle weakness, right? I hope this was pretty clear, because option A, vitamin B3, very easy to rule out. It leads to pellagra. The 6 Ds we have discussed multiple times, right? Here also we mentioned about it. Next, vitamin D, definitely in children it will lead to rickets. In adults it leads to osteomalacia. ये भी discuss हुआ था class में. Vitamin K, definitely it usually leads to hemorrhagic disease of the newborn. Okay, or it can lead to bleeding. Right. Next, if I talk about this question number 137. Dystrophin protein. Okay, dystrophin protein is absent in now. So dystrophin protein is usually encoded by the dystrophin gene. इसके बारे में एक बार mention किया था मैंने class में, that dystrophin gene is the largest gene, right? And it is located on the chromosome number 1, right? So dystrophin gene will encode the dystrophin protein, and dystrophin protein is absent in cases of option B, Duchenne's muscular dystrophy, DMD. Right? So Duchenne's muscular dystrophy, definitely a similar and a confusing term would have been Becker's muscular dystrophy. Yes, Becker's muscular dystrophy is also a similar condition which will resemble Duchenne's muscular dystrophy, but it was pretty clear, guys, that Duchenne's muscular dystrophy mein there is complete deficiency. First thing. Second, it is a severe form of the disease. Third thing, it presents early in the age. Whereas Becker's muscular dystrophy जो discuss हुई थी, sir would have definitely mentioned that Becker's muscular dystrophy usually appears late in the age group. Second, it is milder form or milder variant of Duchenne's muscular dystrophy, right? So these are the two important things you need to remember about Becker's muscular dystrophy, right? So usually a dystrophin protein is absent in cases of Duchenne's muscular dystrophy, right? Completely absent. Whereas Marfan syndrome mein there is defect in the fibrillin gene, right? There was defect in the fibrillin gene. Right, this question had come earlier. We have discussed this also. Marfan syndrome, there is defect in the Fmge gene. Right. Next question number 138. A 11-year-old child presents with palpable purpura on buttocks and lower limbs with abdominal and joint pain. Lab findings reveal hematuria and a normal platelet count. Likely diagnosis is. Now what easy question you need in the examination, because this was a direct repeat. Okay, some changes here and there might have been, but all of you were able to recall this very properly and clearly. This question was also discussed in the last medicine session that we had, right? Important because I told you that vasculitis are important and HSP is very important question which have been repeated multiple times. So the almost a similar kind of question was present. So a child presenting with a palpable purpura on the buttocks and the lower limbs, just as shown in this image, along with abdominal pain, joint pain or arthralgia. Lab findings reveal hematuria and a normal platelet count. Likely diagnosis. First of all, let's rule out. If cola colored urine would have been mentioned, definitely PSGN would have been our first choice. But as definitely hematuria is mentioned, then also we could not rule out PSGN because PSGN can be one of the causes, right? But important thing, usually in cases of PSGN, cola colored urine is mentioned in the question. Second, there is a history of sore throat given prior. Right, so none of this is usually present, and abdominal and joint pain are less likely, or this kind of palpable purpura is less likely with PSGN. Then if I talk about immune thrombocytopenic purpura, the name itself mentioned thrombocytopenic, that means decreased platelet count. So in this question they had directly given that there was a normal platelet count. Definitely, so ITP can be easily ruled out, right? Then if we are left with IgA nephropathy and Henoch-Schönlein purpura, both of these conditions can also lead to the conditions like hematuria vagera. Abdominal pain can also be seen. But as we have discussed that IgA nephropathy is a cause of hematuria, but more commonly in adults. Right? In children, either it can be PSGN or it can be a vasculitis like Henoch-Schönlein purpura. And if some palpable purpura on buttocks and lower limbs are mentioned along with some gastrointestinal symptoms, the condition is very clear to us that the answer would have been option B, Henoch-Schönlein purpura. Right? So Henoch-Schönlein purpura means there are palpable purpura on buttocks, lower limbs along with abdominal and joint pain. Okay, and as it is an IgA related disease, definitely it can lead to glomerulonephritis, further leading to hematuria. Right? Important. Next, question number 139, and the question states, a patient sustained a blunt trauma to the abdomen and in an accident and was brought to the emergency room. He is unstable and BP records 90 by 60 mm of Hg. You initiate basic resuscitation with IV fluids and fast is positive. His condition does not improve despite giving IV fluids. Next step in the management is. So now this similar kind of situation we had discussed in the surgery chantings also. So I hope it was pretty easy for you to come to a conclusion. So patient sustained a blunt trauma to the abdomen after an accident. He was brought to the emergency room. He is unstable, and we have discussed we term a patient hemodynamically unstable if the shock index is more than 1, and the shock index is equal to heart rate upon systolic blood pressure. That means the patient is suffering from tachycardia and the patient is in hypertension. In such condition, the shock index goes beyond 1, and that is the condition when we term it the patient as hemodynamically unstable. They have directly given that the patient is unstable and BP also is recording less, that is 90 by 60 mm of Hg. The first step, as we have discussed, if a patient is hemodynamically unstable, is basic resuscitation. But the question itself mentions that you initiate the basic resuscitation with IV fluids and then you send the patient for fast. Okay, so a fast is done. Okay, focused assessment by sonography in trauma. So fast usually is ultrasonographic procedure. In this you see that the fast is positive. That means there is some internal bleeding going on into the peritoneal cavity. His condition does not improve despite giving IV fluids because there is constant bleeding going on into the peritoneal cavity. So what should be your next step? So in this condition, the next step we have discussed, it is immediate exploratory laparotomy. Okay, to stop the bleeding, the first thing that we need to do is option A, exploratory laparotomy. Otherwise, if the patient would have been stable, then definitely a first line management would have been a fast, and then to confirm our diagnosis, we would have sent the patient for a CECT abdomen. But as the patient is deteriorating, his BP is falling. Okay, so in this condition, as we have discussed already, we need to stop the bleeding. That is our primary aim. We need to save the patient, and therefore immediate exploratory laparotomy is to be done to identify the bleeding site and to stop the bleeding. Right? I hope this is pretty clear. If the patient would have been stable, definitely CECT would have been our second choice, like after a fast. Right? Laparoscopy is definitely not indicated in a hemodynamically unstable patient. MRI abdomen out of choice. Next, question number 140. A patient is brought to the emergency with hypertension, raised JVP, along with neck vein congestion and inaudible heart sounds. He dies in the hospital. And the autopsy reveals the below given image finding. What is the most probable cause of death? So now, I am just not sure, most of the people have given me the recall that definitely these features were mentioned in the question. If these features were mentioned in the question, guys, your diagnosis would have been pretty clear. Even not looking at the image also, you would have been able to make a diagnosis for this condition. So if I move towards making a provisional diagnosis, they have directly mentioned about the Beck's triad in the question, right? If you properly look at the question, they have directly given you about the Beck's triad. First is hypertension. Second is neck venous congestion due to raised jugular venous pressure. Third is inaudible or muffled heart sounds. And this is the Beck's triad, which is directly suggestive of cardiac tamponade, right? It is directly suggestive of cardiac tamponade. Important. And this is a classical image that is present for cardiac tamponade all over. So please remember, guys, usually the condition, if you are not able to recognize it from the image, so the question was pretty clear. I have told you always the question gives you multiple hints towards the answer. Definitely in this question also the answer would have been option D, cardiac tamponade. Okay, because the Beck's triad was clearly mentioned. Pneumothorax is out of choice anyways because no features. Definitely there is a distended neck veins, as ABC is discussed in pneumothorax by me already. ABC हमने बात करी थी that there would have been absent breath sounds, there would have been breathlessness, and third finding would have been congested neck veins. But the other two findings are absent definitely, so pneumothorax is easily ruled out. Fat necrosis, most of the people were confused, guys. So please remember, even if it looks like fat necrosis, definitely not fat necrosis. Okay, important. Fat necrosis we already saw in pathology also. In fat necrosis, usually there is a what we can say, a chalky white material that would have been seen, right? So that was already discussed. And perforation peritonitis, no signs of perforation peritonitis as such are given, right? Next, if I talk on question number 141, a patient was brought to the casualty following a road traffic accident. His BP recording is 90 by 50 mm of Hg and Glasgow coma scale is 9. He is having visceral injuries, likely bleeding, which is the least likely cause of hypovolemia in this patient. So definitely a patient sustained some road traffic accident. Now the blood pressure is falling down, that the patient is suffering from hypertension. GCS scale is definitely 9. He is having some visceral injuries. Okay, important. The person is having visceral injuries to the important organs, and most of the visceral injuries are likely bleeding, which is the least likely cause of hypovolemia. Now they have asked you least likely cause. Okay, so now let's rule out one by one. Option A says hemothorax. Yes, in cases of hemothorax there is high amount of bleeding, and as there is excessive amount of bleeding because the thoracic cavity is larger in size, therefore more and more blood will accumulate inside the cavity, and in cases of hemothorax also there is higher chances that there would be excessive bleeding landing of the patient in hypovolemia. Second is splenic rupture. As we have discussed, usually in cases of blunt trauma, the most common organ injured would be the spleen, and if there is splenic rupture, it is a visceral parenchymatous organ. Definitely there would be excessive amount of bleeding. Okay. Next is retroperitoneal hematoma. As we have discussed in the retroperitoneum, there are major vessels. वो 3 retroperitoneum के zones discuss किए थे. I hope all of you remember that now. that zone 1 usually consists of the major blood vessels like aorta and the inferior vena cava. So if there is any retroperitoneal hemorrhage, therefore there would be excessive accumulation of blood in the retroperitoneum, definitely landing up the patient in excessive bleeding or hypovolemia finally. But in cases of subdural hemorrhage, guys, there is a limiting skull bone or the cranial cavity that would not let excessive bleeding to occur. And if excessive bleeding occurs, definitely that would definitely not land up the patient in hypovolemia. Okay, itni excessive bleeding nahi hogi because the skull is the limiting cavity, right? So important thing is that the least likely condition would be subdural hemorrhage. Yes, definitely at times it can also lead to hypovolemia, but not very commonly as compared to the other conditions in the options. Important thing, you would have got confused with this GCS. So please remember, guys, if the patient is suffering from hypotension, if the BP is suddenly falling, definitely the cerebral perfusion would also be affected. Right, the brain blood vessels would not get enough of blood supply. So if the cerebral perfusion is not proper due to hypovolemia, definitely the GCS score will fall. Okay, that was a likely cause that would have been for the GCS to fall at 9 almost, which is indicative of some moderate head injury. Right, I hope this was easy. If not easy, at least you were able to rule out. If not, don't worry about that. Moving further to question number 142, and the question states, a mother notices that the scrotal sac of her 8-month-old child is empty while giving birth to him. What shall be the most appropriate management? Usually I have discussed in surgery and urology sessions also that such kind of questions in and around testes have been common, and this time there were a lot of questions on testes, guys. There was a question on testicular tumor, there was a question on undescended testes, there was even a question people are recalling about testicular torsion. Okay, so there were a lot of questions on testes this time, so please don't ignore this topic, urology as such, because questions have been asked from these topics as well. So guys, in this condition, please see, so the mother notices that the scrotal sacs of her 8-month-old child are empty. Okay, and what shall be the most appropriate management? We also discussed this earlier when we were discussing about urology. Undescended testes, usually these are the testes when they descend down from the abdominal cavity to the scrotal sac, they get arrested. Okay, and the most common site of arrest usually is the inguinal canal. Right, so definitely the testes would be arrested at the site of the inguinal canal. But in most of the cases, what happens, till 6 to 7 months of age, ये हमने discuss किया था class में, till 6 to 7 months of age usually, or the testes will descend down. Right, spontaneously, you need not do anything for the child. So you need to wait till 6 to 7 months of age. This definitely Jay sir would have also discussed in his sessions. Till 6 to 7 months, the testes will descend down on its own. Right, the testes will descend down on its own. You need not do anything. But in our case, the child was 8 months old. Okay, just confirm me the age once again, because most of the people are telling me 8, so I'm going with 8. So the child was 8 months old, therefore definitely there is no need to wait for the testes to descend down, because we have waited for 6 to 7 long months now, and therefore it is an indication that we can perform a immediate surgery, and we definitely fix the testis in its appropriate place, that is orchidopexy is to be done. Definitely we have discussed that the better time to be done is like 9 to 12 months, or at least we should do it before 12 months. Right, I told you that it should be done before 12 months. Usually we prefer doing it within 9 to 12 months, but in this case, as the child has surpassed the age for wait and watch, definitely we need to perform an immediate surgery, in this case orchidopexy. Okay, so spontaneous resolution is only seen up till the age of 6 to 7 months, not beyond that. Right. Next, question number 143. Identify the type of incision given in the following image. So I was not able to collect the image properly, but whatever I have got, that definitely there was some lady, because people were saying that there was they could identify the vagina, and there was some scar-like image over here. Okay, there was some scar-like image on the lower abdomen present. Okay, and this scar-like image on the lower abdomen, most of them said that this was resembling a fan and steel incision. This was resembling a fan and steel incision, usually given in cases of lower segment cesarean section. And if it was a phalangeal incision looking like lesion, or a lower segment scar of for cesarean section, definitely please remember guys, usually it would have been a surgical incision, right? Most of you have marked it the same. Occupational mark nahi tha, most of them are saying tattoo, it was not there, so it was just a scar due to some surgical incision, so it was pretty clear with this. Next is question number 144. 50-year-old man underwent a surgery for a lipoma present on the nape of the neck. After a few months, he notices a scar and burning sensation. The scar is limited to the wound margins. Which type of lesion is it? Now, it was pretty easy because we have discussed it already in the scar section. Adverse scars is due to increased deposition of the collagen and fibroblast. We discussed if they are of two types, hypertrophic scar and keloid scar. Important thing to differentiate, we discussed that hypertrophic scar usually is limited to the wound margins, and this was specifically mentioned by many of the students in the recalls that so yes, that it was mentioned that the scar was limited to the wound margins. If the scar is limited to the wound margins, definitely your answer should go towards option C, hypertrophic scar. Only and only if the scar extend beyond the wound margins. Okay, if the scar extend beyond the wound margins, in a claw-like manner, usually that the answer would have been keloid. Right, important. But in this case, just after a surgery of lipoma at the nape of the neck, the patient has a scar and burning sensation, which would have been common with both of them, but the only differentiating factor was this, that the scar was limited to the wound margins, so your answer changes to hypertrophic scar, right? Moving further, question number 145. A 25-year-old male had an allergy with the presence of rash with itching. Which type of antibody is responsible for this type of reaction? So I hope this was pretty clear with everybody. I have given it in the last two slides of pathology. I have added for immunology, right? I have given like two slides with mnemonics for your hypersensitivity vagina, and I hope nobody have made mistakes in this. But because the thing is, we have discussed this multiple times in many questions in pharma also and pathology also, right? So a 25-year-old male had an allergy. Only this word was enough for you to come to a conclusion. As we have already discussed, allergic conditions are like allergic conditions or any of the anaphylactic conditions, they are usually type 1 hypersensitivity, and these are usually IgE mediated. Wherever there is an allergy, there would be increase in IgE levels, right? So please remember, the patient had an allergy with presence of rash with itching. Which type of antibody is responsible for this reaction? So it is option B, IgE levels would have been elevated, right? Important. If it was after sensitization, this we have discussed in asthma properly, that if it is after sensitization, Tarun sir has also mentioned in his sessions that after the first exposure, if the question had mentioned clearly, then definitely your answer would change. Okay, there would have been a drastic change in the answer if the question had clearly mentioned that the patient had a previous exposure or multiple exposure, or the patient was desensitized, or after sensitization, something of this kind even was present in the question. Definitely your answer would change to IgG, because in chronic conditions or in recurrent conditions, definitely the IgG would come in action. Okay, in the first or the shocking dose, definitely it is your IgE, but after in the second dose, it is usually IgG which comes in action. I hope this was clear to everybody. Next, moving further, question number 146, which is the type of hypersensitivity in cases of rhesus incompatibility. Again, a very easy question, definitely discussed in pathology, discussed in OBG also by Prasan sir. So it was very easy for all of you. हमने भी बहुत बार discuss किया है कि like rhesus incompatibility में what happens usually, antibodies are formed, right? So as the baby's blood is mixed with the mother's blood, what happens usually, the baby's blood or the baby's RBCs are considered as foreign, right? And as these are considered foreign by the mother's body, therefore antibodies are produced by the mother's body against these RBCs, and as antibodies are produced, an antibody induced or antibody mediated type of hypersensitivity is type 2, that is option A, cytotoxic hypersensitivity, right? So type 2 hypersensitivity is nothing but antibody mediated or cytotoxic hypersensitivity, which is all, and one of the examples is rhesus incompatibility. Okay, any of the transfusion reactions for that matter are an example of cytotoxic type 2 or antibody mediated hypersensitivity, right? Anaphylactic or IgE mediated, as discussed in the previous question, it is type 1 hypersensitivity. Okay, important. Cell mediated is usually a delayed type of hypersensitivity, which is type 4, and immune complex mediated, as seen in conditions like SLE vagera, it is antigen antibody complex mediated hypersensitivity, which is type 3, right? I hope everything is clear with this. Moving further to question number 147. Which of the following molecule helps in adhesion of leukocyte to the endothelium? Very easy again. So now they have given some cell adhesion molecules and they have asked which of the following is responsible for adhesion of a leukocyte to the endothelium. And this was discussed in inflammation part of pathology chanting also, and in Tarun sir's notes also, in Fmge notes it is clearly mentioned that it was pretty easy for all of you. I hope most of them have recalled that integrins was not present in the options. Like even the fourth option, they have said that it was not integrins. They were not able to recall it properly, but they definitely said it was not integrins. So it was pretty easy that for adhesion of leukocytes to endothelium, a molecule responsible is selectin. The marker is CD62. Okay, and selectins are usually responsible for rolling and adhesion. The leukocytes will bind and they will roll and adhere. This is due to the weak affinity, okay, weak affinity of the selectins towards the leukocytes, right? Important. So option B, selectins, was your answer. PECAM1, that is platelet endothelium cell adhesion molecule 1, is responsible for diapedesis, that is for transmigration of leukocytes from the blood vessel lumen to out of the blood vessel. And second is your C5A, which is a most potent chemoattractant, as we discussed. It is responsible for chemotaxis, that is migration of the leukocytes from the blood vessel site to the what we can say, the bacterial site, right? Important. So this was easy again. Question number 148 now. Question number 148 states, a patient underwent gastrectomy few months ago and now presents with fatigue and pallor. The tongue shows below given finding. Likely deficiencies. Now I hope I have covered two questions already of the same vitamin deficiency. This was the third question from the same one in this examination. I was not sure why these people are so obsessed with vitamin B12 this time. So they had given that the patient underwent gastrectomy. So if there is removal of the stomach or there is gastrectomy, there would be decreased amount of parietal cells. Alright, and as we all know that the parietal cells are responsible for secretion of HCl, that is your hydrochloric acid, and second one, it is your intrinsic factor of Castle. ये हमने discuss कर लिया था, right? So intrinsic factor of Castle, this was rather discussed multiple times, right? So parietal cells are responsible for HCl as well as intrinsic factor of Castle secretion. If there is gastrectomy, the parietal cell amount goes down. HCl तो कम होगा ही होगा, उसके साथ intrinsic factor of Castle level will also go down. If intrinsic factor of Castle goes down, definitely vitamin B12 absorption would be impaired. Why? Because as we have discussed that intrinsic factor of Castle and vitamin B12 form a complex together, and this complex is absorbed then from the terminal ileum, right? So if there is gastrectomy, decreased amount of parietal cells, decreased amount of intrinsic factor of Castle, decreased complex formation, therefore decreased vitamin B12 absorption from the terminal ileum. And therefore the patient will present to you with anemic symptoms like fatigue and pallor, along with this fissured tongue all over that you can see. And definitely people mentioned that B2 was not given in the option, sir. So there was no issues for you to get confused, because in B2 we can see geographic tongue or atrophic glossitis. So if people would have been confused, they would have been confused with this only. Otherwise there was no reason for you to get confused, because in vitamin C bleeding comes, we said. Vitamin D usually rickets, osteomalacia. Vitamin B1, it is seen in polished rice eaters, which is usually seen in cases of beriberi. Okay, in chronic alcoholics, it is Wernicke-Korsakoff syndrome. So the answer to this question would be option B, vitamin B12. Next, question number 149. Which of the following method is used for illegal abortion? So now this was again easy, I hope so, because like one of the options you were confused with was Solapith, and Solapith is actually used for cervical dilatation वगैरह to mature the girls before age for the sexual exploitation purposes. Okay, Solapith is used for that condition, whereas abortion stick is usually used for criminal abortions or illegal abortions, right? Next is question number 150. A patient presents with fever, weight loss and chronic fatigue to the OPD. Pallor is noticed on inspection. Hepatosplenomegaly is noticed on palpation. CBC reveals hemoglobin of 7 gram per deciliter. TLC, total leukocyte count of 2500 cells per cubic millimeter, and platelet count of 1 lakh cells per cubic millimeter. Likely diagnosis is. Now, as we had said that definitely CBC count कम से कम तुम्हें याद रहना चाहिए, and that definitely appeared in the examination also, that minimum these like CBC counts you people should remember. Right, we discussed about hemoglobin values. Usually if we take all over males, females, 12 to 16 is the normal hemoglobin value. Less than 11 is considered anemia. In this it is 7, definitely it is severe anemia. TLC count is also gone down because the normal TLC count is between 4000 to 11000 cells per cubic millimeter. Here it is 2500. Platelet count is usually considered normal from 1.5 to 4 lakhs. Here it is 1 lakh cells per cubic millimeter. So definitely there is pancytopenia. Right, all the cell levels are gone down, so there is pancytopenia, right, important, along with features of pallor, fatigue, weight loss. Okay, all of these are suggestive of anemia, right? So in this condition, guys, please remember, in this condition, like some people are mentioning, there was a history of chronic illness given. Okay, if there was a history of chronic illness, definitely a diagnosis will incline towards anemia of chronic disease. Otherwise, if all the cell lineages are gone down, definitely the diagnosis will more likely point towards aplastic anemia. Okay, important. So whatever history I have got with that, the answer would become aplastic anemia. Alright, important. Next is question number 151. A glass industry worker was diagnosed with silicosis who was having respiratory distress. What finding is expected to appear on his chest x-ray? कितनी बार discuss हुआ ये class में question? It was also discussed in pathology. It was also discussed in PSM. Every time we came across silicosis, we have discussed this, right? And like you all were quite aware. I hope nobody has made mistakes in this. So usually silicosis we discussed, it is usually seen either in sandblasting industry or rock industry. Some people mentioned that sir it was rock industry. So rock industry workers, sandblasting industry, glass industry workers. Okay, so in this profession usually the person will likely suffer from silicosis and the patient would have respiratory distress. What finding is expected to appear on his chest x-ray? Here we have clearly mentioned that on the chest x-ray I have told you that there would be multiple reticular nodular opacities which will give a snowstorm appearance, right? We have discussed on a chest x-ray if there is a snowstorm appearance, it is likely to be silicosis. If on an ultrasound there is a snowstorm appearance in a female, it is likely to be a complete or vesicular mole. Both these questions have appeared in this examination, right? Important. I hope this was easy. Honeycomb appearance is usually seen on a HRCT chest or bronchiectasis, right? So bubble appearance is seen on an abdominal x-ray of generalized peritonitis, right? Pleural calcification is seen on a chest x-ray finding of asbestosis. ये भी हमने discuss कर लिया था, right? So I hope it was easy for you guys. Next is question number 152. Which substance is secreted by the parafollicular cells? Now most of you have marked it right. So it was also discussed in surgery. Every time we came to this point where we were discussing about medullary carcinoma of thyroid, I made sure that you remember this fact that medullary carcinoma of thyroid arises from the parafollicular C cells, okay, and these parafollicular C cells are responsible for secretion of calcitonin, right, and therefore the tumor marker for medullary carcinoma is calcitonin. This was the basic funda I gave you every time we came across this funda, this point of medullary carcinoma. right? I hope you remember this clearly. So the answer to this question, that the parafollicular C cells will be responsible for secretion of option A, calcitonin, right? So this parafollicular C cells की embryology पहले पूछी गई थी from the ultimobranchial bodies. This time they asked you the hormone. It was pretty clear. T3 and T4, it is secreted by the follicular cells of the thyroid, right? On the other hand, some people were confused with parathormone, guys. Parathormone is usually secreted by the follicular cells of the parathyroid gland. Parafollicular C cells usually are responsible for secretion of calcitonin, right? Next, moving further to question number 153. Here the question states, a 23-year-old young male patient was found to have a testicular tumor. Lab findings reveal elevated LDH levels and the histopath is given below. What is the diagnosis? Now definitely if they have mentioned that there was a young male in the question, right, having a testicular tumor, definitely the most common testicular tumor in a young person, it is usually a seminoma, right? So उसके साथ तो easy हो जाता. Along with that, they have also discussed one more finding that we discussed already, and they mentioned that the LDH levels were found to be elevated. The tumor marker for seminoma is lactate dehydrogenase. Like most of the seminomas are LDH positive. Alpha fetoprotein is not positive for most of them, right? So LDH levels were elevated. Along with that, histopath was given. Histopath was showing this fibrous septa. Right, histopath was showing this fibrous septa along with cells having a clear cytoplasm and two prominent nucleoli. So usually that was not very much clear, but at least all of these other findings were pretty what we can say clear, that the diagnosis in this question would have been option B, seminoma. Teratoma, as we discussed, it is usually a tumor arising from all the three germ cell layers and definitely will give rise to all the three germ cell derivatives as well. Sertoli cell tumor, the tumor marker would not have been LDH, more likely it would have been testosterone, because testosterone would be elevated along with LDH, but definitely the histopath findings would not be such as fibrous septa. Right? So I hope this was easy. Moving further to next one, question number 154. A patient was diagnosed as a case of supraspinatus tendinitis. What degree and movement of shoulder would be painful? So guys, most of you were confused with this. So important thing is supraspinatus tendinitis, important. It is a cause of painful arc syndrome. Important. Along with subacromial bursitis, supraspinatus tendinitis or supraspinatus calcification, all of these are causes of painful arc syndrome, right? And painful arc syndrome का मतलब क्या होता है? Not pain while abduction from 0 to 15 degree, rather it is pain in the mid range. That means when you are performing abduction from 60 degrees to 120 degrees, there would be pain. Not below that, not above that. Pain will disappear above that and below that. Only between 60 to 120 degree there would be pain, and this mid range pain is known as the painful arc syndrome. And the most important cause is supraspinatus tendinitis, right? Important. And in this case, therefore, your answer would have been option B, that is 60 degrees of abduction. Definitely most of you are right that supraspinatus muscle is responsible for abduction from 0 to 15 degrees, guys. But please remember, supraspinatus tendinitis, usually the inflamed part passes via the tunnel, okay, and whenever the inflamed part passes via the tunnel, then and then only the pain would appear. And whenever there is a movement in the mid range or there is abduction in the mid range, then the tendon is passing via the via the tunnel, okay. Beyond that, the tendon will pass through, and beneath that the tendon is not going into the tunnel, therefore the pain would not be appreciated. So 60 to 120 degree of abduction will lead to this painful arc syndrome, and the most important cause is supraspinatus tendinitis. Next, question number 155. A person met with an accident and as he was driving the car. Following injury, his lower limb was in flexion, adduction and internal rotation. X-ray done is given below. What is the most probable diagnosis? Now, a similar kind of X-ray was given in the Fmge snaps, even discussed by sir also in his sessions. So it is very easy. They have directly given the attitude of the limb, that the patient has flexion, adduction and internal rotation. So if you take the initials of everything, it becomes to be father. And we have discussed the father attitude of limb. मैंने बोला भी था P for papa, father, उससे याद रख सकते हो तुम. Therefore it is usually seen in cases of posterior hip dislocation, right? So the answer to this question would have been option D, posterior hip dislocation. If you see the x-ray also of the pelvis, here you can see that the femoral head is dislocated posterior to the acetabulum. Now most of the people were confused that sir, it was fracture acetabulum. Guys, please remember, in cases of fracture acetabulum, definitely there would have been some kind of internal rotation vagara. But important thing, here you could have seen that the femoral head would go inside the pelvic cavity because it is known as a central fracture dislocation. This is the hip joint. Okay, whenever there is fracture acetabulum, most of the cases that the femoral head would go inside the pelvic cavity. So this is the picture let us see. But most of them have said that the femoral head was dislocated posteriorly. It was not seen into the pelvic cavity. Therefore, the answer to this question, more appropriate answer would be posterior hip dislocation. Father is the important and appropriate attitude of limb which is seen in cases of posterior hip dislocation, which is usually seen in cases of dashboard injury whenever a driver or the occupant of the first seat is there, and whenever they sustain an accident, definitely they hit their knee hit the dashboard, and definitely the femoral head is pushed backwards, right? This we have discussed, and posterior hip dislocation is the most common type of hip dislocation in the that is seen, right? Important. Next, question number 156, it states that burden of disease in a society is best indicated by. This was also orally discussed by me. Definitely we have discussed that what is DALY. So DALY is disability adjusted life years, right? And we said that disability adjusted life years usually would be an indicator of the burden of the disease, right? So important. So direct answer to this question is that the burden of disease in a society is best indicated by option B, DALY. This was a repeated question again, so it was easy to be marked, right? Incident is the new number of cases, easy to be ruled out. Prevalence is the total number of cases, new as well as old cases. Case fatality rate is definitely not an indicator of disease burden. Rather, case fatality rate is indicator of the disease mortality. Right, important. So case fatality rate is कितने मरे total measles के cases में से how many died, that is what the case fatality rate tells us. Right. Next is question number 157. Registration of births and deaths at state and national level is done under which system? So I hope this was pretty clear. Maybe definitely you would have confused it with census. So guys, हमने registration of births and deaths एक ही जगह पे mainly पढ़ा है, and that was civil registration system. मैंने बोला भी बार बार that civil registration system में we have to register their birth and death within 21 days and marriage within 30 days. Okay, whether it is at the city level or a state level or a national level. Why civil registration system would be the best answer, guys? Because it is a continuous system. Every day registrations हो रहा है. Okay, every day birth and death registrations are taken under the civil registration system. If I talk about sample registration survey, guys, definitely I mentioned this, that sample registration survey is the most accurate data collecting system because it is done every 6 months. But I have said it is data collecting system. It will not only focus on births and deaths, rather it also focuses on your MMR, IMR, okay, crude birth rate, crude death rate, everything. Okay, and it is conducted every 6 months. But important thing, everyday registrations are going on in the civil registration system. So if they ask you, the most appropriate answer to this question would have been option D, civil registration system. We discussed this in civil registration system. You can find in the chanting PDF even that like birth deaths registration should be done under the civil registration system, right? Important. National Family Health Survey, it is conducted every 5 to 6 years. So definitely not of youth. Census every 10 years. So better answer would have been civil registration system. And that is the reason why I told you that sample registration survey is considered better at times over the census because it is conducted very frequently. Next question number 158, guys. Now it states, under ESI Act, a registered medical practitioner can give which of the following service to the beneficiary in rural areas? So now guys, I hope this was easy. Like we have discussed that the ESIC, that is your Employee State Insurance Corporation, this ESIC was constituted under the Ministry of Labour under the ESI Act. Okay, So under this ESI Act, this ESIC was formulated, and under this ESIC there are many ESI hospitals. Okay, many ESI hospitals all over the country, and these ESI hospitals also have their dispensaries, but usually they are present in urban areas like Pune, Mumbai, Delhi. All of these cities, usually these ESI hospitals are present. So if a patient from a rural area wants to take benefit of any of the health benefit under the ESI scheme, because as we have discussed, under the ESIC scheme usually the employer pays 3.25% of the wages, whereas the employee pays 0.75% of the wages, and all this contribution goes to the ESIC corporation, under which they provide you free health cover for you and your family if your income is less than 21,000 per month. This was discussed, so it comes under the Ministry of Labour. So if a person comes to the ESI hospital directly and gets the his treatment done or his diagnosis done, definitely it would be an example of direct health benefit. But in this case, they have said a person living in a rural area and he is taking his treatment from a registered medical practitioner. Okay, so if service is given by a registered medical practitioner or any of the empaneled hospitals for that matter, okay, so any empaneled hospitals, for example in ESIC, I was working in ESIC, so it is better for me to tell that in ESIC usually they have a scheme that if there are no proper facilities or diagnostic services or treatment services available in ESIC hospital, the patient have to be sent for other hospitals, the empaneled hospitals the patient are sent. So this scheme where the patients are sent to some other empaneled hospitals for diagnostics or treatment, or they are taking treatment from some other registered medical practitioner, this comes under an indirect health benefit for which they receive some amount. Okay, for which this receives some amount, health amount. They need to pay first of all and then they receive some amount. Okay, so this is an example of option C, indirect health benefit. So I hope this was easy. Next one, question number 159. While performing a clinical trial, the selection bias can be removed by, and this I hope was very clear, because in epidemiology first slide itself we discussed about this, that confounding removal or any of the bias for that matter, I have mentioned that confounding or any of the bias, it can be removed most commonly by matching, but it is best removed by randomization. If the question would have mentioned stratified randomization, that would have been the best answer. ये भी हमने क्लास में डिस्कस किया था. If the options mention stratified randomization, that would be the best answer. If not, then randomization would be your second best answer. So in this question, a stratified randomization was not present, so the answer would have been randomization. So selection bias or confounding, they are best removed by randomization. Matching is the most common technique used for removal. Blinding is also used, but better one or the best one that is used is randomization, right? Next one, question number 160. It states that a maize-eater individual presents with complaints of diarrhea, dermatitis and dementia. The likely diagnosis is. So I hope this was pretty clear now. 3Ds to आ ही गए थे. There is diarrhea, there is dermatitis, there is dementia. So at least you would have known that the condition is mentioning about pellagra. ऊपर से they even mention that the person is a maize eater. This question we have solved already in the PSM chanting, like towards the end when we were solving some previous year questions. I have mentioned that maize in daily diet is associated with deficiency of, and the answer to this question was option B, niacin B3 deficiency, which leads to pellagra. Right? So as maize is deficient in lysine and tryptophan, as tryptophan is a precursor for vitamin B3, as tryptophan would be deficient in maize eaters, therefore niacin or vitamin B3 will also not be formed, and if niacin or vitamin B3 is not formed, it would lead to pellagra, which will manifest as diarrhea, dermatitis, dementia, depression, delirium and death. Right? I hope this is pretty clear with everybody. So, and one more important point that I have mentioned here also, I have mentioned, okay, so in this QRS session also I mentioned this, in questions also I mentioned this, everywhere we were discussing about this. So usually in maize there is one pellagrogenic amino acid, that is leucine. So usually leucine stops this conversion, right? Leucine stops the conversion from tryptophan to vitamin B3. मतलब एक तो tryptophan की कमी भी है body में because maize is deficient in tryptophan. Second, leucine which is present in maize, it is also impairing the conversion of tryptophan to vitamin B3. That will lead to decrease in vitamin B3 levels, leading to pellagra. I hope this is pretty clear. So the answer to this question would be option B, pellagra. Next, question number 161. Vitamin K is given to a child at birth for prevention of. जब हम NIS discuss कर रहे थे, in PD also Dr. Nasar sir would have mentioned about this. Vitamin K we were discussing in National Immunization Schedule also when we were discussing the vaccines given at birth. I told you guys important जो vaccines birth पे दी जाती है like BCG, OPV and hepatitis B. Along with that I also mentioned that injection of vitamin K is also given at birth, right? And this injection of vitamin K is given to prevent option A, hemorrhagic disease of newborn. Right, so for prevention of hemorrhagic disease of newborn, usually we give the child vitamin K. If the child is less than 1 kilogram or less than 1000 grams, usually the child is given 0.5 mg of vitamin K. If the child is more than 1 kg or more than 1000 gram, then the child is given a dose of 1 mg of vitamin K. Right, this I have mentioned already. So I hope it was pretty clear. We have clearly discussed in class that vitamin K deficiency can lead to hemorrhagic disease of newborn. And as ये भी mention हुआ था that the breast milk does not have sufficient amounts of vitamin K and vitamin D. Therefore, vitamin D is given till 1 year of age. Vitamin D is given till 1 year of age, 400 international units. ये भी mention किया था, right? I hope this was clear. So with this you were able to solve the question easily. Next is question number 162, guys. Reinfection of which of the following disease will be more severe due to antibody response? So guys, please remember reinfection or secondary infection, whatever was mentioned. Please remember in case of dengue usually we have D1, D2, D3 and D4 serovars, right? So all these serovars, definitely if there is infection with D1 and the next time the person is getting infected with D2, the infection would be much more severe. The disease would be much severe. If the person had suffered from just dengue fever in first infection, in the second case the infection can further progress to dengue hemorrhagic fever or dengue shock syndrome even. Okay, so this is due to the various serogroups of dengue in which the secondary or the reinfection will become much more severe due to the preformed antibody responses. Okay, so the answer to this question would have been option C, dengue. Next is question number 163. Which of the following has the lowest glycemic index? A question from Barkan, definitely Priyansar would have mentioned in his sessions. So like it was pretty easy. I feel important was to rule out the fruits easily because the highest glycemic index, I hope all of you know, the reference glycemic index is of glucose, that is considered 100% or 1. Okay, apart from that, all of the fruits which will have high amount of glucose or fructose will definitely can be easily ruled out, that is papaya or watermelon. Definitely watermelon has 73-74 glycemic index, so it can be ruled out. Papaya is also a sweet fruit. Then definitely potato usually has a glycemic index around 65 and sweet corn has a glycemic index around 55, and that is why sweet corn is usually recommended for diets वगैरह, whereas potato is not as such recommended for diets, right? So in this the answer would have been option A, sweet corn. Question number 164. The total number of maternal deaths related to pregnancy per 1 lakh live births is known as. So important thing is guys, यहाँ याद रखो हमने डिस्कस किया था कि maternal mortality MMR जो होती है maternal mortality rate या maternal mortality ratio, it is actually a ratio. ये मैंने बार बार बोला था. Why it is a ratio? Because A upon B into 1 lakh हमने हर बार डिस्कस किया था that 1 lakh is the multiplier, first thing, therefore it cannot be a rate. Second thing, that A is not a part of B. Why A is not a part of B? That means maternal deaths upon live births, right? So maternal deaths are not among the live births. Right now, so therefore A is not a part of the B, or numerator is not part of the denominator, and that is the reason why it is not a rate, rather it is a ratio. Therefore, if they have mentioned in the question clearly that total number of maternal deaths per 1 lakh live births, then the answer would have been option A, maternal mortality ratio. If they would have mentioned that the total number of maternal deaths, total number of maternal deaths upon the female in the reproductive age group, that is between 15 to 49 years of female, then your answer would have been maternal mortality rate, because then we are actually calculating the rate, because here the maternal deaths are among the 15 to 49 years or reproductive age group females only, right? Important. For proportion, definitely it is expressed in percentage, right? So the multiplier should have been 100. Next question, number 165. A 11-year-old child presents with swelling over the face and is unable to chew the food. He also develops a painful swelling over the scrotum. What is the likely diagnosis? So it was pretty clear, if a child is having a swelling over the cheek or the face, along with that there is also a swelling in the testis or the scrotum, it is more likely to be mumps. Why it is more likely to be mumps? Important, guys, we have discussed this, that usually mumps is nothing but parotitis, that is inflammation of your parotid salivary gland, okay, due to which there is swelling, diffuse swelling over the face and the cheek. Along with that, the patient is not able to chew the food properly. Next, along with that, if there is the most common complication of mumps in adolescence age group is usually orchitis, that is inflammation of your scrotal sac, right? So these are the two findings which are commonly related to mumps. Measles definitely manifests with erythematous rash all over the body, and usually the complication of measles is otitis media, not orchitis, right? Important. Diphtheria also, we discussed that there would be a bilateral cervical lymphadenopathy leading to bull's neck, which was the image in Fmge June 2021 session, not this one, right? Important. Rubella, we have discussed about the Bullberry muffin rash and all the congenital rubella syndrome. Next question, number 166, guys. It says a 5-year-old child presents with poor school performance and hearing loss. The child also has breathing difficulty. What is the preferred management for this child? So now a school-going child, okay, usually a 5-year-old child with poor school performance, and important thing is hearing loss. Likely we suspect in a child of school-going age, if there is hearing loss, it would likely be gluvia. But this gluvia, along with that, the child is also having some breathing difficulty. If the child is having breathing difficulty, definitely we will suspect there is adenoid hypertrophy, right? Till 6 years of age, there is presence of adenoid in the nasopharynx, right? And there can be adenoid hypertrophy. And if the adenoid undergoes hypertrophy, there would be blockage of the eustachian tube. If there is blockage of the eustachian tube, there would be it would lead to serous otitis media, also known as gluvia, right? That would further lead to hearing loss. So if the child is having poor school performance along with hearing loss and a breathing difficulty, it is likely to be adenoid hypertrophy. If feces vagara would have been mentioned, pinch nose vagara, then it would have been much easier. So the answer to this question would be option B, adenoidectomy along with grommet insertion for middle ear ventilation to be done, right? Next, question number 167. Now they have just given you the auscultation areas and you had to identify the correct marking. So it was very easy, I hope, for all of you. We will go this according to the image. So the area which is marked A, it is in the second second intercostal space on the right side, right? Second intercostal space on the right side, and it is the auscultation area for important. It is the auscultation area for your aortic valve, you can say, or the semilunar valves. Okay, so first area which is marked A is the aortic area. Second, the area B which is marked, it is again in the second intercostal space, but it is on the left side or the left sternal border, and it is usually your pulmonary area, right? It is your pulmonary area where you auscultate for your pulmonary valves or for your semilunar valves again. Next, the C area which is marked, usually you can see it is usually in the first, second, third and fourth intercostal space. If it would have been in the third intercostal space, guys, then it would have been your Erb's point, okay, which is the central point. All of you would have studied in therapy. It is the central point, Erb's point, but it is in the fourth intercostal space on the left sternal border again, right? So important, it is your tricuspid area, right? This one is your tricuspid area. And the last one that we have, the area which is marked D, it is located in the fifth intercostal space on the mid-clavicular line. So this is also known as your apex beat, Here you palpate for your apex beat or auscultate for your mitral area, right? Important. So A, aortic, B, pulmonary, C, tricuspid, and D, mitral. So the answer to this question would be option A, right? Next, 168, which is the enzyme deficiency seen in cases of galactosemia. So I hope it is pretty clear. There were two questions on galactosemia. First of all, absolute contraindication of breastfeeding is galactosemia. In lactose intolerance and galactosemia, the child is not able to digest breast milk properly. Along with that, the second question was the enzyme deficiency in cases of galactosemia, and as we know, in classical galactosemia or type 1 galactosemia, which is the most common type of galactosemia, the enzyme deficiency is option A, GALT1, right? I hope all of you were able to mark it correct. Galactose phosphoruridyl transferase 1. Okay, so this is the enzyme deficiency which is seen in cases of classical galactosemia, which is much more common. Yes, most of the people said that galactokinase was also an option. So please remember guys, galactokinase, even it was an option, but the more common one is the classical galactosemia due to GALT1 deficiency, right? So that would have been a more appropriate answer for you. Question number 169, which among the following is the correct statement about Trotter's triad? So now we have already discussed about Trotter's triad in ANT rapid revision session. Here I have given you the mnemonic UPT for Trotter's triad. Trotter's triad we discussed, it is found in cases of NPC, nasopharyngeal carcinoma, right? And Trotter's triad is remembered by UPT, U for unilateral conductive hearing loss. Okay. Second, it is due to the blockage of the eustachian tube by the tumor or the mass, we can say. Second, P for palatal palsy due to involvement of the 10th cranial nerve or your vagus nerve. Last is your T for trigeminal neuralgia due to involvement of your 5th cranial nerve. So the option A suits best, that is palatal palsy, trigeminal neuralgia, and conductive hearing loss, right? I hope this was pretty clear for all of you. Question number 170 now. All the below given statements about the condition in the image are true except. So now you need to find an incorrect statement or exception. So what was the image given? So most of the people have recalled that on the extensor surfaces, sir, there was some plain topped papules given. There was some plain topped purplish color papules given. So 6 P's, that is plain top purplish color pleuratic papules, they are usually suggestive of nothing else but lichen planus. Definitely this you have discussed in derma also. So these are the findings seen in cases of lichen planus, right? So in lichen planus you need to rule out one by one. Wickham's try, yes, in lichen planus. In lichen planus, guys, definitely Wickham's try is due to the oral involvement, oral mucosal involvement. Okay, there are whitish striae or whitish color patches in the oral cavity in lichen planus which are seen. Those are known as your Wickham's striae. Next, civate bodies are seen on the biopsy of the skin in cases of lichen planus. Along with that, sawtooth acanthosis some people are saying, and some people are saying there was sawtooth retinitis. It was sawtooth retinitis, then no issues to get confused. But if it was sawtooth acanthosis, definitely some people would have at least got confused with this option also. But definitely please remember guys, Kogo's abscess is not a finding with lichen planus, rather Kogo's abscess is a much more specific finding of psoriasis vagera. Okay, so important thing is this would have been an exception for you all. Next, question number 171, it states a patient complains of diarrhea and abdominal pain. The organism was seen to have tumbling motility. What can be the likely cause? Now we have discussed rest questions of microbiology already. This Vikas sir would have definitely taken in his sessions even. So patient complains of diarrhea and abdominal pain. Organism was seen to have tumbling motility. So if an organism is seen to have tumbling motility, it is nothing else but option A, Listeria, because Listeria has tumbling motility. Vibrio cholerae usually has darting motility, and the question would have mentioned definitely rice watery diarrhea, and Giardia usually it has a falling leaf-like motility, right? All of this would have discussed multiple times by sir in his sessions or in other sessions too. Next, question number 172, a 65-year-old patient went for gallbladder removal, and after 2 days of surgery, she presents with complaints of right hypochondriac pain and fever. Lab investigation shows leukocytosis and liver enzymes and amylase were normal. What can be the likely cause? So now a patient went for gallbladder removal, cholecystectomy was done. After 2 days of surgery, patient complains of right hypochondrium pain and also fever. Lab investigation shows leukocytosis, but the liver enzymes and amylase were perfectly normal. So if amylase is normal, acute pancreatitis can be ruled out in this case. CBD stone, it would have been a case, but please remember guys, in cases of CBD stones, usually the liver enzymes found to be elevated, at least ALP vagara is elevated in cases of obstructive jaundice. Here they are saying that liver enzymes are perfectly normal. So the most likely answer to this question would be option B, bile leak. Okay, so if there is a bile leakage, usually that can be a case of right hypochondriac pain. Along with that, there would be fever, right? Next question, number 173. An elderly lady presents with pain in the right hypochondrium. Ultrasound abdomen reveals a gallbladder polyp. What is the next line management? So now most of the people have given me the recall that there was a symptomatic patient mentioned in the question, that the lady had pain in the right hypochondrium. If the patient has pain in the right hypochondrium, guys, and if the ultrasound abdomen reveals a gallbladder polyp, then the next line of management would definitely be option C, laparoscopic cholecystectomy. But if the patient was asymptomatic totally, the patient was just diagnosed with a gallbladder polyp, then the answer would have been reassure the patient and follow-up to be done. Okay, a close follow-up to be done if the patient was asymptomatic. Otherwise, laparoscopic cholecystectomy is indicated, right? Next, question number 174. The below given image is, so this was the image that was marked, I hope, and it was pretty easy for all of you to just identify the image. This was just your ovarian, the ovarian cycle, which was given when a primordial follicle develops into a primary follicle. From that it develops into a secondary follicle. So a primordial follicle, when it is surrounded by these cuboidal granulosa cells, then it turns into a primary follicle. When it is there are layers of granulosa cells surrounded with theca cells, it turns into a secondary follicle. Then it turns into mature follicle, and then like 6 to 7 follicles they develop, and they develop a cavity inside them which contains some fluid, and this cavity which contains some fluid, such kind of a follicle with multiple layers of granulosa and theca cells, is known as a option C, antral follicle, right? So this was definitely mentioned by Prasan sir in his sessions also, so it was easy. Then question number 175. A child was brought with cyanosis which decreases with crying. What is the likely management? So this is pretty easy, guys, I hope so. If a child was brought with cyanosis, definitely that the child is suffering from respiratory difficulty, but as soon as he opens the mouth for crying, definitely ventilation is proper and the cyanosis will decrease. So if the cyanosis fades away when the child cries, that means the oral the oral airway is intact, but there is some problem in the nasal airway. That means likely the child is suffering from choanal atresia, more commonly bilateral choanal atresia. So whenever the child tries to breathe from the nose, the child would not be able to breathe properly. There would be respiratory difficulty and cyanosis. But whenever, as soon as the child starts crying, the oropharyngeal airway would open and the cyanosis will decrease, right? So in this cases, the option B, oropharyngeal airway, should be given to the child. That would be the best thing to be done, right? Question number 176. Mr. Z comes to a doctor for severe headache. Doctor asks him to go for a CT head. Later on, the radiologist visits the doctor for Thanksgiving with an envelope. What is the correct statement? So definitely Vikas sir would have covered this in the FMG sessions even. So whenever a doctor takes some amount of commission from another doctor or some amount of gifts from another doctor, this is usually known as fee splitting, right? And fee splitting is in medical terms or jurisprudence terms, it is known as dichotomy. So here the doctor is likely practicing dichotomy. Okay, fee splitting or dichotomy is practiced by the doctor. Okay, because he recommends the patient to go for a CT head without a valid reason, and then after when the radiologist comes to the doctor, he hands him over an envelope which would contain some amount of money or some amount of gift. Okay, So that is dichotomy. Question number 177 and last for today's session. A patient was brought to the surgical emergency with ascites and perforated peritonitis. Ascitic tap was done, which reveals peritoneal abscess along with some fecal matter. What is the best management? So guys, please remember, as we have discussed multiple times, peritoneal cavity, pleural cavity, usually these are cavities, mediastinal cavity, these are cavities which are serous cavities and which are very clean. So if they are contaminated, definitely there would be inflammation. Okay, there would be peritonitis, which would be which would be very painful. Along with that, the patient can land up even in sepsis or septicemia, and that is highly fatal. So in these cases, whenever there is a case of perforated peritonitis, always and always the patient is to be operated. Whether there is a peritoneal abscess or fecal matter or not, that is secondary, but the patient is to be operated. So I got a recall that in every other option, reanastomosis was given. So if reanastomosis was given, you have to actually just figure out the best option for yourself. So option A says peritoneal lavage, that means cleaning of the peritoneal cavity and reanastomosis of the ruptured segment. This looks quite a better option. Option B says exploratory laparotomy and reanastomosis of ruptured segment. Exploratory laparotomy is to be done. Definitely it should be done in the first case even. Okay, जब तुम exploratory laparotomy करोगे तभी peritoneal lavage भी कर पाओगे ढंग से. So definitely exploratory laparotomy is to be done, but not only exploratory laparotomy, but a peritoneal lavage is also indicated. Why? Because if you wash the peritoneal cavity thoroughly, then and then only the inflammation will not set in and the patient will not land up in sepsis. Okay, that is the reason behind we need to wash the cavities thoroughly. Peritoneal lavage is to be done thoroughly, and then you reanastomose the ruptured segment. Okay. So with this, I complete the session for today. Thank you so much. If you have some more questions, guys, please feel free to comment them in the chat box below, or you can just message me on the Telegram. Because whatever questions I had, I still have some amount of questions left, but at least those questions I do not have proper options for them, or at least they are not framed in a proper way which will resemble your exam pattern questions. So I would like your help. If you could help me out on the Telegram also, so it is accepted and appreciated. So thank you all of you, those who were able to give their opinions and suggestions for all the questions till now. If you are able to give me more questions and more recalls, definitely I can come up with the next video even. Till that, take care, goodbye. Don't be more anxious about your results. Okay, everything will fall in place. Just be calm, quiet. All the very best for your results from Fmge and my side. Thank you so much.